So we'll start with the adnexal follicular tumors, and so and I'll also be sharing a PowerPoint with you guys, which talks about the syndromic associations. But what makes something follicular driven is the presence of keratin-derived cystic lesions. So if you see horn cysts which have keratin within it, then that's basically follicular in derivation. Now, the follicular tumors are derived from varying portions of the hair follicle. So to recognize the normal anatomy is important because you can, once you recognize what structure it is arising from, the classification of the tumor becomes easy. So this is an example of an epidermoid cyst, and this is not going to be asked in your boards. It's too simple of a question, but I wanted to illustrate what infundibular follicular keratinization means, and that is the formation of keratin through the presence of a granular cell layer. So when you see formation of keratin through the presence of a granular cell layer, that's infundibular keratinization, and that is what is seen in an epidermoid cyst. A smaller variant of an epidermoid cyst is a milium. So if you see a similar small cystic lesion with the infundibular keratinization, which is again keratinization through the presence of a granular cell layer, that would be milium. If you see multiple of these cystic lesions which are attached to the overlying skin, then that would be like a comedone. The next pattern of keratinization is your trichilemmal keratinization, which is what you see in a pallar or trichilemmal cyst. So trichilemmal keratinization is derived from the isthmus part of the hair follicle. And here you see keratinization through the absence of a granular cell layer. So you do not see granular cell layer. It's pretty abrupt keratinization. And the trichilemmal cells are going to have lots of pink eosinophilic cytoplasm, and they're often pale appearing. But you can see that there is keratinization and no granular cell layer. So that's what you see in a pallar cyst or a trichilemmal cyst. An important board question is your proliferating pallar tumor. And this is often confused either with the squamous cell or with the pilomatricoma. So you have to be careful with the pattern of keratinization, and also recognizing that the entire proliferation is confined within the cyst lumen. So you can see the well-circumscribed cystic structure, and the wall of the cyst has proliferated with this trichilemmal keratinization. So the wall is thick, but to call it malignant, you have to see clear-cut invasion into the stroma or presence of tumor necrosis. Now, as an important reminder, any malignant counterpart, like a malignant pallar tumor, a trichoblastic carcinoma, anything pilomatric carcinoma, these are typically wrong answers and they are distractors on your boards. So you do not want to pick them up. Extremely rare malignant variants of adnexal tumors are extremely rare. The only one which is probably board testable are the ones that I will tell you about. Other than that, they are pretty distractors on your board. This is you can see that the wall of the cyst has proliferated, and it is nicely showing the trichilemmal keratinization, which is again keratinization through the absence of a granular cell layer with these lining abundant pink cells. The reason I said that this can mimic a pilomatrical tumor is because if you just go directly into the tumor and start looking at the keratin areas, you may start imagining shadow or ghost cells. But remember that the pattern of keratinization in a pilomatricoma is different. It's derived from the matrical part of the hair follicle. So we'll see that the keratinization pattern is very different. So this is trichilemmal keratinization, where you see keratinization in the absence of a granular cell layer. And this is an example of proliferating pallar tumor or proliferating trichilemmal cyst. Another important board question is what we refer to as a hybrid cyst. A hybrid cyst is a cyst which shows keratinization or from a dual pattern of follicular differentiation. So two patterns of follicular differentiation are seen. The most common is a combination of follicular and infundibular keratinization. So you can see here keratinization through the presence of a granular cell layer, and the adjacent, what is known as your matrical differentiation, where you see keratinization through the presence of shadow or the ghost cells. So that is a dual hybrid cyst, which is often seen in a Gardner syndrome. So I will talk about a pilomatricoma very soon. And pilomatricoma is going to be characterized by the presence of these shadow ghost cells, as you can see in here. But most importantly, you will see the matrical component of the tumor, which I'm going to illustrate really soon. So this is a hybrid cyst, which is seen in Gardner syndrome. Pilomatricoma is derived from the lowermost portion of the hair follicle. So the matrical component of the hair follicle. Now, remember, the matrical component of the hair follicle is extremely proliferating. So this cyst often has two components to it. It has the basaloid, the germinative cells, which you can see in here, and the shadow or the ghost cells, which you can see in here. If you just pay attention on the basaloid component, it looks pretty bad. It will have mitotic activity because it's one of the most proliferating center of the body. But this is all benign. This is just the germinative or the matrical portion of the hair follicle. And right adjacent to it, you have these nice outlines of the shadow cells. You can see the shadow or the ghost cells. There is often an associated granulomatous inflammation with giant cell reaction to the ruptured keratin. And often there is secondary dystrophic calcification. And hence it is also called calcifying epithelioma of Malherbe. In a pilomatricoma, which shows the predominant basaloid component, they will definitely try to confuse you with, again, a pilomatric carcinoma. So remember, that is going to be the wrong answer. We do not want to pick that up. So this is a nice example of a pilomatricoma. The other second order associations with it: myotonic dystrophy, Gardner syndrome, the matrical component of the tumor, this blue cells, they often show staining with beta-catenin, nuclear expression of beta-catenin. So all those things can be asked as second order questions. So this is a nice example of a pilomatricoma. Okay. Now, let's come to your next cyst, which is also a follicular tumor, which is a steatocystoma. So steatocystoma classically has a collapsed lumen. So when you look at it at low power, the lumen looks kind of collapsed, and the lining epithelium of the lumen has this undulating pink eosinophilic epithelium. So if you notice in over here, these cells lining the cyst, they are bright eosinophilic cuticular lining. So this bright pink eosinophilic lining, as you can see in over here, and the wall is kind of undulating. It's kind of wavy. The wall of the cyst often has sebaceous lobules in it, and that's a steatocystoma. Now, the sebaceous lobules in the cyst wall can also be seen in a dermoid cyst. So a dermoid cyst will also have sebaceous glands in the cyst wall. But the difference is the lining epithelium. In a dermoid cyst, the lining epithelium is going to be like your epidermoid cyst. So you will see the follicular keratinization. Whereas in a steatocystoma, you will see the lining epithelium is going to be this bright pink eosinophilic cuticular lining. Steatocystomas are often sporadic and isolated lesions, but you can see them in eruptive form in steatocystoma multiplex. You can see them in Pachyonychia congenita. They the other thing about steatocystomas is that this lining epithelium, what you see in over here, is the lining epithelium of an odontogenic keratocyst, which you see in the mandible in the Gorlin syndrome, which is your the patch tumor suppressor gene associated nevoid basal cell carcinoma syndrome. So that's another question that can be asked: that what is this lining epithelium similar to? It's seen in an odontogenic keratocyst, which is a tumor in the jaw, which occurs in patients with Gorlin syndrome. So you should know about that. So that's just steatocystoma. Very much related to a steatocystoma is a villus hair cyst. The villus hair cyst can also occur in an eruptive fashion. So you can have eruptive villus hair cyst. A villus hair cyst looks pretty much like an epidermoid cyst. So the lining epithelium has the same lining, the follicular infundibular keratinization, but the lumen has a number of these aborted villus hair shafts. So you can see the nice villus hair shafts in the cyst lumen. So it looks like an epidermoid cyst, but the lumen has all these aborted villus hair shafts. Okay, so do you guys have any questions till now? Okay, so let's continue with the next spectrum of tumors, and that would be dilated pore and your palar sheath acanthoma and trichofolliculoma. So they are all in a spectrum. What do they share in common is that they all have this central dilated cystic opening, which is filled with laminated keratin. So you can see this large follicular infundibular opening, which is connected to the epidermis. But the wall of the cyst has minimal epithelial proliferation. So that's your dilated pore of Wiener. A dilated pore of Wiener, which is on steroids, is going to be your pilar sheath acanthoma. So in a pilar sheath acanthoma, you again have a central cystic invagination, and from the wall of the epithelium is much more thick and has these acanthotic pink buds arising from it. That's your pilar sheathocanthoma. Now, the pilar sheathocanthoma, the lining epithelium of a pilar sheathocanthoma is going to be derived from your tricholemmal cells. So remember, we talked about tricholemmal epithelium being present in a tricholemmal cyst. So similarly, the wall of the proliferating cyst is going to be lined by this thick epithelium, which has this pink eosinophilic pale cells, and that's your tricholemmal epithelium. So a dilated pore with a much more thick wall and pink acanthotic buds arising from the cyst wall. So that is going to be your pilar sheathocanthoma. The classic location of this lesion is on the upper lip. One step beyond it is going to be the trichofolliculoma. The trichofolliculoma is classically referred to as mama and baby appearance. Now, this has it's a very classic appearing tumor. If you've seen it, you'll always remember it. It has a central cystic invagination, and radiating from the central cyst are all these immature hair follicles. So you can see these nice immature hair follicles radiating from the central cyst. Now, it may not be in a perfect configuration always like this. So this is like a really nice example of it. Sometimes, depending upon where the lesion has been cut, you have to kind of imagine the central radiation. So the central cystic connection may not be that very obvious. So for example, in this case over here, you can see all these radiating immature hair follicles. They're coming out from what looks like the central cystic opening, but you cannot see the central cyst, but you can see the nice radiating immature hair follicle. So that is your trichofolliculoma. Now, if these immature hair follicles also have sebaceous glands in them, that is referred to as a sebaceous trichofolliculoma. So now you can see that from the central cyst, you again have these radiating hair follicles, but the wall of the have a number of this sebaceous glands, as you can see in over here. So that's your sebaceous trichofolliculoma. This, you can forget it. If you don't want to remember it, it's fine, but you do need to know about a trichofolliculoma. Having said this, now let's talk about tumors which are derived from sebaceous glands. So let's first talk about the sebaceous hyperplasia. Now, firstly, you need to understand the anatomy of a sebaceous gland. So each sebaceous gland is composed of the outer basaloid layer, which is your germinative layer. You can see this nice compressed blue layer, which is your basaloid germinative layer. And then the inner cells, which are referred to as sebocytes. So the sebocytes are these cells with multivacuolated cytoplasm and crenated or bummed up nucleus, as you can see in here. So these are the germinative cells and these are the sebocytes. In sebaceous hyperplasia, you just have increased number of the sebaceous glands. You do not have proliferation of the basaloid layer. So, and it often is connected to the central kind of like cystic hair follicle, and then the number of sebaceous glands is increased. So that's sebaceous hyperplasia. If you get proliferation of the basaloid germinative layer in a benign fashion, then you are going to get either a sebaceous adenoma or a sebaceoma, which is also referred to as a sebaceous epithelioma. So both sebaceous adenoma and sebaceoma or sebaceous epithelioma, these are benign sebaceous tumors. So benign sebaceous tumors, we have to raise the possibility of the Muir-Torre syndrome, which is the loss of the MSI genes, the MSI gene expression. So we mentioned that. And the important thing is to make sure that this is not a sebaceous carcinoma. The distinction whether it is a sebaceous adenoma or sebaceoma in real life is not that important. But your boards do like to ask them. So the rough rule is that here you can see that this is a sebaceous tumor. Why? Because you can see proliferation of the basaloid cell layer along with the sebocyte. So both are increased. So that makes it a sebaceous tumor. But what makes it a sebaceous adenoma is if the number of the sebocytes, the white areas, are more than roughly 50%. So here you see predominantly it's more of the sebocytes rather than the basaloid cell. So that makes it a sebaceous adenoma. These sebaceous adenomas, they can be pretty big. Often the center portion will show this kind of what appears to be necrosis, but it's not really necrosis. It's like keratin debris within the lesion. So that's your sebaceous adenoma. It's important to recognize these tumors on low power because low power is important for distinguish from a sebaceous carcinoma. You can see that overall the lesion is very well circumscribed at its edges, even though it's cut off at the base, is very well confined. So there is no infiltration into the dermis to suggest invasion. The next entity is going to be your sebaceoma or sebaceous epithelioma. Here you will get the proliferation of the sebocytes and the basaloid cells, but the basaloid cells are forming more than 40%, 50% of the lesion. So you mostly see the blue areas. Sebaceomas or sebaceous epitheliomas will be your closest mimicker of a sebaceous carcinoma. So again, recognizing it on low power, seeing that the lesion is pretty well circumscribed, it has got smooth edges, it's just cut off at the base. And then common to both sebaceous adenomas and sebaceoma will be the central, like this kind of pink keratin debris. And within the cells itself, you can see that there will be mitotic activity, but it's not very predominant. It's not significant cytologic atypia, but most importantly, the lesion is well circumscribed. So that's your sebaceoma. Both sebaceous adenomas and sebaciomas, especially when they occur outside the head and neck and in a multiple fashion, can be associated with Muir syndrome. To assess for Muir syndrome, we will do immunohistochemical expression of the Muir markers, which are the markers of microsatellite instability, which are your MLH1, MSH2, MSX6, and PMS2. The most commonly lost in the skin tumors associated with Muir is going to be the MSH2, which results in the loss of downstream products, which is MSX6 and PMS2. So it's MLH1, MSH2, MSH6, and PMS2. Now, this is going to be in contrast to your sebaceous carcinomas. Now, sebaceous carcinomas can be extraocular or it could be periocular around the eye. So the periocular sebaceous carcinomas are actually associated with HPV infection. So they are not Muir associated, but they are associated with HPV infection. It's the most common, second common malignancy of the eyelid following your other basal or squamous cell carcinomas. So on low power, these tumors will look very blue. So they can see a very blue looking tumor. You will see areas of infiltration into the dermis. So you can see here invasion that is occurring into the dermis. And the tumor itself will have the very blue areas. The blue areas are going to be much more atypical, mitotically active with true necrosis, as you can see in over here. And then the white area are essentially the more benign component of the lesion. Not really benign, but they are not the relatively bad looking component. You can see the sebocytes. And that will help you to recognize that this is a sebaceous tumor. So you can see the sebocytes, the cells with a multivacuolated cytoplasm and a crenated nucleus. But the basaloid cells, they are clearly atypical. The tumor has invaded into the dermis. So this is a sebaceous carcinoma. And both periocular and extraocular sebaceous carcinomas will show a similar histology. So you cannot really distinguish them. But extraocular sebaceous carcinomas are most often associated with Muir syndrome. So that's your sebaceous carcinoma. So let me show you some more examples. So another example of sebaceous carcinoma. So in low power, this tumor will look extremely blue, as you can see in over here. You can see its invasion into the dermis. When you go up on high power, you can see that it has a lot of the blue basaloid cells, which are clearly very atypical looking, very pleomorphic. They have scattered mitosis and apoptosis. You can see the central tumoral necrosis. This pink is the necrotic focus within the tumor. And then you have the blue, the basaloid areas, which are basically going to be, have cytologic atypia and mitotic activity. So this is your sebaceous carcinoma. The extraocular sebaceous carcinomas, we are always going to work it up for associated Muir syndrome. So loss of MLH1, MSH2, PMS2, and MSH6. And any one or more of these markers will be lost. Even if one marker is lost, that's indicative of microsatellite unstable pattern. Do you guys have any questions till now? Okay. Now let's go to your next spectrum of tumors, which will be your trichoadenoma, trichoepithelioma, and a trichoblastoma. So now why are these tumors in a spectrum? Because all these tumors have similar things in common, which is the presence of horn cysts and the presence of these immature basaloid follicular islands. You can see the horn cysts within the lesion, and you also see these immature basaloid follicular structures, as you can see in over here, these kind of like what appeared as immature hair follicles. If a lesion has predominantly the cystic structure, so it predominantly has horn cysts with very little of the immature hair follicles, it's a trichoadenoma. It's the least common among the trichoadenoma, trichoepithelioma, and trichoblastoma. So you can see the nice uniformly placed horn cysts with these immature hyperchromatic basaloid islands. So that is your trichoadenoma. The most common among all of these is going to be a trichoepithelioma. So in a trichoepithelioma, it's the prettiest looking of all the follicular tumors and the closest differential of a basal cell. An important thing about the trichoepithelioma is that the stroma is an integral component of the lesion, and you often see stroma to stroma retraction. So you can see the nice retraction of the stroma from the adjacent tumor, whereas in a basal cell, you get tumor to stroma retraction. Here you get stroma to stroma retraction. And the tumor consists of scattered haunches, as you can see in over here, and all these immature follicular islands, which have very prominent structures known as the papillary mesenchymal body. So what is a papillary mesenchymal body? Papillary mesenchymal body is condensed mesenchymal stroma, which is grabbed by this claw-like extension of the follicular epithelium. So it looks like a claw of the follicle is grabbing the stroma. That's your papillary mesenchymal body. Does everybody see that over here? So that's your papillary mesenchymal body. So papillary mesenchymal body doesn't mean anything much. It basically means that this tells you that this lesion is derived from a hair follicle and that it is a benign follicular tumor. And it is not something like a basal cell. And it is derived from the immature portion of the hair follicle. So these are all your basilar follicular islands. Couple of them are showing papillary mesenchymal bodies. They're scattered haunches within the lesion. They're not as much as what you would see in a trichoadenoma, but they are there. And you can see the nice stroma of the lesion, which is nicely pink, and it shows nice retraction from the adjacent stroma. So stroma to stroma retraction is important in a trichoepithelioma. Interestingly, the stroma in a trichoepithelioma will stain strongly with CD10. Now, don't like to use a lot of markers in your Adnexal tumors. Immunohistochemistry is not typically useful, but in a scenario like this, it is useful. The CD10 in like superficial shape biopsies, when you're trying to decide whether this is a benign follicular tumor, or is it something like a basal cell, then stains, especially the CD10, can be helpful. So you can see how nicely the CD10 is just highlighting the stroma and it spades the follicular island. So it's a crisp demarcation between the follicular islands and the stroma. That's indicative that this lesion is basically benign and not a basal cell, as a sharp distinction in the basal cell between the tumor islands and the stroma is going to be lost. So that's your trichoepithelioma. The extreme end of the spectrum is your trichoblastoma. Trichoblastoma, these can pretty be large and big lesions. Clinically, they often always you think about a basal cell, but you can see histologically there are barely any haunches, very few haunches, or if none. And then you have all these immature follicular epithelial islands, which look exactly like the papillary mesenchymal bodies of a trichoepithelioma. So you can see papillary mesenchymal bodies, you can see these immature hair follicles, it can undergo all these immature hair follicles. And again, you see the stroma, which is an important component of the lesion, and stroma to stroma retraction can also be seen. So you can see the nice pink stroma. Now, there are not many haunches in the trichoblastoma. That's how you differentiate it from a trichoepithelioma, but it predominantly has these immature follicular epithelial islands with the papillary mesenchymal body. So that is your trichoblastoma. Most often, trichoblastomas end up getting excised. Not that they need excision, but it's not uncommon that when we sign out of trichoblastoma, it ends up with an excision. So, I often like to say that this is a benign follicular tumor and you can simply watch this site. So this is your trichoblastoma. Any questions? Okay. The next tumor that we are going to talk about is going to be mostly the tumors which are derived from the outer ridge sheath of the hair follicle, which is a tricholemal epithelium. So first among them is your tumor of follicular infundibulum. Tumor of follicular infundibulum, these are pretty small tumors, which are basically most commonly located on the head and neck, especially the central portion of the face. And what you see in here is that the tumor itself looks surrounding from the adjacent epidermis. So you can see that these are these anastomosing plates and cords of epithelial islets which are arising and oriented perpendicular to the epidermis. And within these nodules of cells or the plates of cells, you can see that there is peripheral palisading like the picket fencing of the cell, but there can be retraction as well, but the inner cells are basically jumbled up with have the pale eosinophilic cytoplasm, which is tricholemal epithelium. So we have talked about tricholemal derivation in your palar sheath acanthoma. We have talked about it in proliferating palar tumor, in palar tricholemal cyst, and then again in tumor of follicular epitheliums. and you can see here these parallel plate-like structures oriented parallel to the epidermis, with the outer palisading and the inner cells which are jumbled up and cleared out, which are all your tricholemal cells. So that's your tumor of follicular infundibulum. So I'll show you another example of it. Um, this tumor, always remember that it is basically much more smaller as compared to the surrounding, much more paler as compared to the surrounding epidermis. So you can see these plate-like structures which are attached to the epidermis arising parallel from it. And you can see, you can appreciate that here how there's a sharp distinction, demarcation between the more pinker cells of the epithelium and little bit lighter staining cells of the epithelium right over here. So that is your tumor of follicular infundibulum. So much more paler as compared to the surrounding skin. Uh, the TFIs are very small. One of the common tumors this is confused with is fibroepithelioma of Pincus or the Pincus tumor. So in fibroepithelioma of Pincus or Pincus tumor, these are variants of basal cell, but they occur in uncommon locations. So the uncommon locations are these may occur in the axilla, in the groin, the lower back, abdomen. So sites where you typically don't think that basal cells will arise. Clinically, they can be large polypoid tumors, taggy tumors, skin within arising within like a what is presumed to be a skin tag is not uncommon. And then the morphology of the lesion is classic. You can see these anastomosing thin strands and cords of epithelial islands which have this condensed stroma entrapped within between them. So you can see these nice thin proliferating strands of basal follicular epithelium, and then you have the correspondingly presence of this nice dense pink stroma. So and in some areas you may see the more conventional basal cells. So you often see like the tumor to stroma retraction. So you can see here, which is a nice feature of a basal cell. So you can see here these cells are retracting from the adjacent stroma. So the more classic features can also be present. So this is a Pincus tumor or fibroepithelioma of Pincus. Um, the next tricholemal tumor we are going to talk about is going to be your tricholemoma. So tricholemomas are tumors which again arise most often on the head and neck. The lip, the nose are common sites. And tricholemoma can either it has a flat surface or it has a verrucous surface. So the verrucous tricholemomas which have a verrucous epithelial proliferation, which I'm going to talk about soon, is called a tricholemal verruca. But both the terms tricholemoma and tricholemal verruca are interchangeable. Okay, so you should not really try to make a huge distinction between the two of them. I will call something a tricholemal verruca when clinically you've thought about a wart or if it has prominent epidermal papillomatosis. But you can see that there is an endophytic nodule which is connected to the epidermis. It is arising from it. When you go up on high power, the periphery of the lesion is again has this nice, the basaloid cells. So you can see these, where did my cursor go? Yeah. So you can see these, the basaloid cells. An important clue for the tumor is to look on low power for the well circumscribed smooth edge of the tumor. And you can see at the periphery of the cells are basaloid, they're lining up, which is called picket fencing, but there is no retraction from the adjacent stroma. And then the inner cells of pilar sheath which are much more paler. As you can see in over here, these have distinct cytoplasmic borders with pale eosinophilic clear cytoplasm because they're tricholemal cells. Again, they're derived from the outer reach sheath of the hair follicle. So that's your tricholemoma. Multiple of these tumors are associated with Cowden syndrome. Now, this is going to be in contrast to your tricholemal verruca, which is also a benign follicular tumor, except that clinically it looks more like a wart. So you can see this nice verrucous epithelial proliferation with these fingers, which is of classic for a wart. But then you can see that in the next level, arising from the basal epithelium of what appears to be a wart, are these nodules of cells. You can see that in over here. They have these large bluer cells, which are going to be your basaloid cells. And then you have these nice cells, which will have the distinct cytoplasmic borders and the pale eosinophilic cytoplasm. So it's just another terminology. This is called a tricholemal verruca, but these are also completely benign. So let me show you another example of tricholemal verruca. Let's see. So this is another example. So you can see here the nice kind of like verrucous proliferation, and then arising from the base, the basal layer, is going to be this endophytic nodule, which has very nice peripheral palisading again, and then the cells have distinct cytoplasmic borders with clear cytoplasm. So that is your tricholemal verruca. Okay, now the one of the things about tricholemomas which can be asked is a desmoplastic tricholemoma. So desmoplastic tricholemomas are more of a derm path board kind of a question, but they can ask you. These can be pretty large and big tumors. And again, on low power view is very important. You can see that the tumor is very well circumscribed. It has a beautiful collarette within the lesion. And then on high power, you see this well circumscribed kind of nodular proliferation. Again, notice on low power, the nice smooth edges of the lesion on either side, the collarette of the lesion, surrounding the lesion. And then you can see the nice basaloid cells at the periphery, and then the inner cells are again jumbled up and cleared up with distinct cytoplasmic borders, which is what you would see in a tricholemoma or tricholemma verruca. Now, because the lesion is big, the center portion of the tumor often shows these infiltrating nests and cords of islands which appear to be present in a hyalinized stroma. That's called a desmoplastic tricholemoma or desmoplastic tricholemma verruca. Where the edges are smooth, you will see the picket fencing of the basaloid cells, the inner jumbled up clear cells, but at the center, as it grows, it shows these tumor islands which are caught up in this hyalinized stroma. So that is your desmoplastic tricholemoma. One of the close differential of a tricholemoma is going to be a palar sheath acanthoma. The reason being both a tricholemoma and palar sheath acanthoma are pale tumors. They derive from the outer root sheath of the hair follicle, which is your tricholemal epithelium, which shows the pale cells. The difference between the pale cell acanthoma the difference between so I was talking about a tricholemoma, and the closest differential diagnosis is going to be with the pale cell acanthoma. The similarity between a pale cell acanthoma and tricholemoma is that they both have the clear cells, but the quality of the clear cells is different. In a pale cell acanthoma, the clear cells are the same cells as the epidermal keratinocytes, except that they have become bigger because of the pale eosinophilic cytoplasm, because there is absence of glycogen phosphorylase. So they're the same as the adjacent epidermal keratinocyte, but in a tricholemoma, the cells are outer root sheath of the hair follicle. So they have an outer palisade and the inner cells which are cleared up with distinct cytoplasmic borders. So the nature of the clear cells is different, and also the architecture is important, because in a pale cell acanthoma, it looks like a plaque of psoriasis because of the nice suprapapillary thinning, the dilated vessels, which will be absent in a tricholemoma. So whenever they show you a clear cell tricholemoma, they will often compare it with the pale cell acanthoma. So you should know the difference. The next entity, which is rare in a follicular tumor, but I'm going to talk about it because they can ask you, is a cutaneous lymphadenoma or an adamantoid trichoblastoma. So an adamantoid trichoblastoma or cutaneous lymphadenoma, they both are in a similar spectrum. As compared to a trichoblastoma, they are variants of a trichoblastoma. So the background tumor looks like the trichoblastic islands, the immature follicular epithelial islands without the haunces, but then there are lymphocytes which are attacking these follicular islands. So this looks like a swarm of bees, lymphocytes which are basically present amidst these follicular epithelial islands. So that's your adamantoid trichoblastoma or cutaneous lymphadenoma. So you can see here these lymphocytes, a swarm of bees which are attacking the follicular epithelial islands. It's uncommon. It's not common. So, if you can recognize an adamantoid trichoblastoma or cutaneous lymphadenoma, you're certainly in the 95th percentile. So, that's really good. The next very common board entity is an inverted follicular keratosis, or an IFK. So IFK is considered by many to be a variant of seborrheic keratosis. By some, it is considered to be a variant of a tricholemal tumor. These can be pretty big lesions. They often clinically come in as cysts or as a squamous cell tumor. They're going to try to confuse you with an SCC, so beware of that. These tumors are also very endophytic, so you can present with an endophytic nodule. And within the lesion itself, you will have the pale cells. You can have the pale cells, but most importantly, you have these concentric round squamous epithelial structures, which are referred to as squamous eddies. So you can see these round whorls of squamous epithelial islands. You can see that over here. These are the squamous eddies. So if you see squamous eddies, the squamous eddies mean that it is not a squamous cell. This is going to be a benign entity, and that is going to be your inverted follicular keratosis. Do you guys all see the eddies?
Yes.
Okay, so let me show you some more examples. Um, it's another example of an inverted follicular keratosis. So these can also be very warty looking tumors. On the top, it can look like verrucous proliferation, but then the bottom, the portion of the lesion is endophytic nodule, and you can see numerous squamous eddies in here. These are very beautiful. You can see the nice concentric squamous epithelial island. So that is your inverted follicular keratosis. When we see the squamous eddies, we do not want to pick up a squamous cell. The next entity we're going to talk about is going to be your it's a hamartoma, which is your nevus sebaceous. So nevus sebaceous is derived from the malformation of the pilosebaceous unit. So clinically, these presents as a verruciform plaque with alopecia. And what you see is because of the immature hair follicle. So what you see is the top of the lesion will look variably papillomatous. So you can see the epidermis shows mild verrucous papillomatous hyperplasia. You can see that. There are number of sebaceous glands because there are no corresponding normal mature hair follicles. So this is how the normal mature hair follicles on the scalp should look like. So you can see how these are the normal hair follicles. You can see how these normal hair follicles are lying down deep in the fat, right? So these will have the nice long hair shafts. So it is aborted. In nevus sebaceous, you do not have normal hair follicles. Instead, you have immature hair follicles. So you can see this tiny baby immature hair follicle. This is the basaloid component of the hair follicle, which should actually be deep down in the fat, and it is tiny. So where is it going to form the hair shaft? You see plenty of these immature hair follicles. There's another hair follicle here. There's another immature hair follicle here. So all these immature hair follicles means that these are prone to develop follicular tumors or adnexal tumors at some point. So you can have secondary tumors arising within the nevus sebaceous. So first of all, you have these immature pilosebaceous units. You have more than the number of sebaceous glands because you do not have the mature hair follicles. So the sebaceous glands disproportionately increase and they're going to all directly open into the surface epidermis. And then you can have secondary tumors arising within the nevus sebaceous. The common ones are your tricholemomas, syringocyst adenomas, tubular apocrine adenomas, trichoblastomas, and even basal cells can arise within the nevus sebaceous. And hence, it's often recommended that the nevus sebaceous should at least be closely followed. And if they have follicular tumors arising within them, they should be excised. So that's your nevus sebaceous. Another clue for nevus sebaceous is going to be when there are apocrine glands on the scalp. So apocrine glands do not occur on the scalp. So this is an example of a nevus sebaceous where you can see the nice verrucous epithelial proliferation. You can see the papillomatosis. You can see all these immature hair follicles with numerous sebaceous glands. But importantly, in the deep in the dermis, you see these apocrine glands. So apocrine glands do not occur on the scalp. So you see apocrine glands on the scalp. That means this could be a nevus sebaceous. The last tumor that I'm going to talk about in this category is really important, and that is your fibrofolliculoma or a trichodiscoma or a neurofollicular hamartoma, which is associated with Birt-Hogg-Dubé syndrome. Now, this is how always a fibrofolliculoma will look like. So I want you to bury this picture in your head. You can see this immature strandy follicular epithelial islands, these really thin follicular epithelial islands, which are these thin cords, which are closely interacting with this pink stroma, which often looks like it is a neurofibroma like stroma. So it is very pink. It has these spindle cells which are delicate, but it's not really a neurofibroma like stroma. It just looks like it. So these thin, strandy follicular epithelial islands interacting with this pink stroma. The classic example is a fibrofolliculoma where you have equal proportions of both. If you have much more of the hair follicular element, that's a trichodiscoma. If you have much more of the stroma, it's a neurofollicular hamartoma. So it's basically a spectrum. The most common one that they will like to ask you is a fibrofolliculoma, and this is how it will look like. It will look like a thin pink follicular epithelial a strand which is interacting with the pink stroma. So that is your fibrofolliculoma or trichodiscoma, which is associated with Birt-Hogg-Dubé syndrome. So those were the follicular tumors that we talked about. Okay, so let's go into your sweat gland tumors, the eccrine tumors, and we'll see how much ever we can cover them. So before we start about the sweat gland tumors, first of all, remember normal axilla. Normal axilla is an important question. They can definitely be asked. The epidermis in normal axilla is often papillomatous. So you can see this undulating epithelium that's common for any intertriginous epithelium. And deep down in the dermis and the fat, you see this continuous apocrine gland. So first of all, learn how to recognize apocrine glands. So how do apocrine glands look like? Apocrine glands will have abundant voluminous pink cytoplasm of the lining epithelium. So you can see these cells which will have voluminous pink cytoplasm with what are known as the apocrine snouts. So you can see this apocrine snouts with the decapitation secretions. That's your apocrine gland. So when you have number of apocrine glands present in a lobulated fashion in the deep dermis, that's your normal axilla. So normal axilla is an important board question. Okay, so now let's start with your tumors. The most common one, starting with the most benign one, is a hydrocystoma. Hydrocystoma is a uniloculated cyst, so a big single lining cyst which has compressed epithelium. So the lining epithelium is columnar or glandular, but it is compressed. So you basically sometimes do not even see the lining epithelium because it is compressed. And the apocrine hydrocystoma is when you can see the lining epithelium. It's also a uniloculated cystic lesion, most common in the eyelid region. So you can see here the nice cyst lining, and the cyst lining has the nice decapitation secretions of the apocrine cell. So that's an apocrine hydrocystoma. If the wall of the cyst now gets to proliferate and it basically forms a multiloculated cyst. So here you can see that this particular lesion has got multiple cystic opening. There is one big cyst here, there is another tiny cyst here, and then you also have this adenomatous proliferation arising from the wall. And then the lining epithelium is again your apocrine. So you can see the nice apocrine cells with the decapitation secretions in here. So that is an apocrine cystadenoma. Why? Because it has the cystic structure and the adenomatous structure. So they're all in a spectrum. So you have an apocrine hydrocystoma. If it proliferates, it forms an apocrine cystadenoma. One step beyond it is going to be your tumor, which is referred to as your tubular apocrine adenoma. Tubular apocrine adenoma is going to occur most commonly on the scalp. Tubular apocrine adenoma and papillary eccrine adenoma are pretty much similar looking tumors. So when you see these ducts in the dermis, as you can see in over here, the three things that come to your mind are tubular apocrine adenoma, papillary eccrine adenoma, and dermal duct tumor. Okay, so if you want to write that down somewhere, when you see these ducts in the dermis like this, the three tumors that come to mind are tubular apocrine adenoma, papillary eccrine adenoma, and the dermal duct tumor. They all have these tubules in the ducts, okay? The tubular apocrine adenoma and papillary eccrine adenoma are basically same looking tumors. The difference is tubular apocrine adenoma occurs on the scalp and papillary eccrine adenoma occurs on the extremities. But they all have these tubules in the ducts, and the lining epithelium, it shows this kind of variable luminal secretions with the proliferating epithelium, which often has apocrine decapitation secretions, or it may form these micropapillary elements. So that's your tubular apocrine adenoma. This one is on the scalp, so I'm going to call it a tubular apocrine adenoma. But I'll show you a papillary eccrine adenoma that also looks really similar, but that occurs most commonly on the extremities, on the hand. So you can see here the thick acral skin. You again have the tubules and the ducts in the dermis, and the lining epithelium is again bilayered. So this is an again important clue. When you see the ducts which are lined by bilayered epitheliums, by bilayered you mean there is an inner and an outer. So you can see two layers of epithelium. This means it's benign because the outer is the basal layer. Okay, when you see complexity of the lining epithelium and there is no presence of the outer, the two-layered structure, then you start worrying. But you can see here, these are the tubules and the ducts. And what is a micropapilla? Micropapilla are these finger-like proliferation into the lumen, which lack a fibrovascular coat. So these small finger papillary structures are all micropapillary structures. So that's very prominent in a papillary eccrine adenoma. But these are the tubules and the ducts, which are lined by this proliferating epithelium. So that's a papillary eccrine adenoma or a tubular apocrine adenoma. The malignant counterpart of a papillary eccrine adenoma, which they are not going to give you a slide of it, but you should know, is an aggressive papillary digital adenocarcinoma that occurs on the digit And those are malignant tumors. They can occur, the most common site is the volar aspect of distal interphalangeal joint. And these tumors are aggressive. They are adenocarcinomas. They can metastasize to the lung, to the lymph nodes, and often digital amputation is required for the treatment. The problem is that on a partial biopsy, a papillary eccrine adenoma will be impossible to distinguish from an aggressive papillary digital adenocarcinoma. So that's the question they can ask you. They can show you a slide of a papillary eccrine adenoma, and then they can ask you that what is the potential tumor that you should be thinking about. And that's your aggressive digital papillary adenocarcinoma. I'm not going to go into the histology of an aggressive digital adenocarcinoma on the digit because it is, it's more of a derm pat both kind of a question, not for you guys. But typically, if on acral skin, so you can see this acral skin, if you see an adenocarcinoma, and why do I say this is an adenocarcinoma? Because this is, first of all, it is infiltrating into the dermis, right? So there is all invasion. There is, you can see this hyalinized stroma, which is invasion, and very complex cribriforming structures. So you can see that the two-layered epithelium is loss, multi-layered epithelial proliferation, so the complexity, and that's why it's an adenocarcinoma. Now let's talk about the tumors which are in a spectrum, and these are all similar tumors, which are syringocystadenoma papilliferum, hidradenoma papilliferum, and your nipple adenoma. So all these three tumors, they kind of have a similar morphology with slight differences. So syringocystadenoma is the most important, very important board question. This tumor always exhibits contiguity with the overlying epidermis, and the transitioning epithelium is very important. So the connection to the epidermis, and then you will see the nice transitioning of the epithelium from the skin. So you can see the stratified squamous epithelium of the skin. It basically transforms into this glandular epithelium, which is bilayered. You can again see the bilayer, the inner and the outer. You can see the cells with the decapitation secretion. As you go bottom, it becomes more proliferating. So it forms the adenomatous structures, the cystic structures, and the papillary structures. So what is a papilla? Papilla are these broad finger-like structures wherein the central fibrovascular core has plasma cells. So plasma cells are an integral component of syringocystadenoma. They can also be seen in a hidradenoma. So you can see this nice, beautiful finger-like structure with the fibrovascular core containing plasma cells. But the lining epithelium, as you can see in here, you can nicely see the two-layered epithelium. So syringocystadenoma papilliferum, you're going to look for the nice transitioning epithelium from the skin to the glandular epithelium, the adenomatous, the cystic, and the papillary structure. So that's your syringocystadenoma papilliferum. This tumor most often occurs on the scalp and can arise in association with the nevus sebaceous. The next tumor is going to be your hidradenoma papilliferum. The hidradenoma papilliferum most commonly occurs in the genitalia, and this grows in a cauliflower-like fashion. So it grows more in parallel fashion to the epidermis. It's not that it doesn't have a connection with the epidermis. It can have a connection, but that nice distinction of the transitioning epithelium is absent, or it may not have a connection with the epidermis. But then if you look within the tumor itself, it's pretty similar to a syringocystadenoma. You can again have the cystic, the same papillary structures. You can again see the two bilayered morphology of the lining epithelium, the inner and the outer epithelium, and this proliferating epithelium. So that's your hidradenoma papilliferum. And again, the papillary fibrovascular cores will have the plasma cells. So, it's pretty similar otherwise to a syringocyst adenoma. The next one is going to be your nipple adenoma, or the fluid papillomatosis of the nipple. That's the other name of it. The nipple adenoma, first of all, you will recognize it to be the nipple because you will recognize the smooth muscle bundle. So that is very important. So recognition of the site is important. So you can see all these smooth muscle bundles in the skin, and that is going to be the nipple region. And these are intraductal papilloma. So they arise from the nipple duct. So you can see at the periphery of the lesion, this is the nice nipple duct. So the nipple duct, which is growing up into the skin, oriented perpendicular to the epidermis, and then arising within the duct is this structure, which will like grow up like a flower. So that orientation would often help you to recognize a tumor. So you can see that this is the ductal stem of the tumor, and then it proliferates out. But within the tumor itself, when you see it has a similar architecture to a hidradenoma or a syringocystadenoma papilliferum, you can see again, the tubules and the ducts, which have this bilayered morphology, the inner and the outer cells with the pink apocrine cells. So that is your nipple adenoma. It can get more complex, but you will clearly see the areas where you will see the bilayered morphology, as you can see in over here. So that is your nipple adenoma. Now let's come to the next category of your sweat gland tumors, which is going to be your poroid tumors. So the poroid tumors are derived from the acrosyringium, and they're all composed of a small, round, monotonous poroid cells. So poroid tumors are classified as poromas, hydrocanthoma simplex, and dermal duct tumors. So we'll talk about all the three. So poromas are the ones which have a nice collarette and they're connected to the epidermis. So arising from the basal layer of the epidermis is going to be an endophytic nodule. The lesion of the cell, the lesional cells, you can see they show sharp demarcation from the adjacent epithelium. These epidermal keratinocytes are much more larger. And then the poroid cells are small, round, monotonous. They are much more smaller. So they are larger, they are smaller. That's how I know that these are poroid cells. Very monotonous proliferation with what you can imagine to be remnants of ductal elements. You can see that these are like forming these, like they are collecting around what appears to be a central lumen, indicating the glandular ductal morphology. So you can see them. This is a nice acrosyringeal being formed in over here. So, but very monotonous, small, round poroid cell. That is a poroma. The classic architecture, limited endophytic nodule, nice collarette is going to be a poroma. If you just have the the cells which are, if it is just a dermal based tumor with ducts lined by the poroid cell, that's going to be a dermal duct tumor. So remember, I told you when you see ducts in the dermis, there are three tumors: a tubular apocrine adenoma, papillary adenoma, and a dermal duct tumor. So you can see the ducts, but what are the ducts here lined by? They're lined by the small, round, monotonous poroid cells. So that's your dermal duct tumor. Again, it is a very classic looking tumor. If you look at it once, you will always remember it. The tumor doesn't have connection with the epidermis. You can see the ducts, and the ducts are lined by the monotonous poroid cell. So that's your dermal duct tumor. The last variant of it is your hydrocanthoma simplex, which is also called an intraepidermal poroma. So hydrocanthoma simplex on low power will really look like a seborrheic cavatosis. So the seborrheic cavatosis, you can see that they grow in a more plaque-like fashion, and often because the epidermis is proliferating, they will have horn cysts looking like a seborrheic cavity. It really looks like a sepke. But when you see within the lesion, it's proliferation of these small non-monotonous poroid cells which are sharply delineated from the surrounding epidermis. So the larger cells and the smaller non-monotonous poroid cells. And then clearly in areas you will see glandular ductal differentiation. You can see the acrosyringeal units being formed in over here. So that's not a seborrheic cavatosis, but it is a hydrocanthoma simplex because it again has intraepidermal proliferation of these small non-monotonous poroid cells. You can see the nice, beautiful, nice sharp demarcation. The poroid cells, these are the keratinocytes. And then within the lesion itself, you can see the nice glandular ductal element. So that is indicated that this is a hydrocanthoma simplex, not a seborrheic cavatosis. The next adnexal sweat gland tumor that we're going to talk about is a hydradenoma. Hydradenoma by far are the most complicated of all the sweat gland tumors that we have talked about. These can be pretty large and bulky. They may or may not show a connection to the epidermis, and they often have either a solid cystic or predominantly cystic or a predominantly solid morphology. So you can see here, this here, it shows connection to the epi, is a big endophytic nodule. It has a cystic component and it has a solid component. When you look in the solid component of the cells, you will see that the cells are essentially of two types. So what do I mean by two types? It's cells which will have more pink cytoplasm and the cells which will have more clear cytoplasm. So pink and the more clear cells. And another important component of the lesion is the stroma. As you can see here, the entrapped stroma is very dense hyalinized, which is called a bubble gum or a chewing gum kind of a stroma. You can see the nice dense pink hyalinized stroma. That's an integral component of a hydroadenoma. And then you can see that this is also, it is, going to form the glandular and ductal elements. So as you move around the tumor, you can basically see the nice ductal elements being formed. But again, please recognize the stroma, this nice densely pink hyalinized stroma, which is useful in recognizing a hydroadenoma. So let me show you some more examples of a hydroadenoma. It's another example. You can see this is a very nice endophytic nodule, which is connected to the epidermis. When you go up on high power, this is a beautiful example of the two types of cells. You can see here the cells with the more clear cytoplasm, the cells with the more pink cytoplasm. They have distinct cytoplasmic borders. Another appearance of feature of the hidradenoma is that the cells are like kind of like elongated with a windswept appearance. So they kind of like look like long polygonal stretched out cells. So that's another feature that helps you to recognize it. But clearly you can see the two types of cells, the cells which have more clear and the cells which have more pink cytoplasm. Again, let me show you another example because this is probably the most, the most difficult tumor of all. You can see the big nodule of the tumor. And then when you go up on high power, you can again see the two types of cells. You can see the clearer cells and the more pinker cells within the lesion. You can again see the kind of elongated, stretched out, the windswept appearance of the cells. And this is the beautiful hyalinized, the dense pink stroma. So that is your more of a solid hidradenoma. And again, this one doesn't have a connection with the epi, but it can have a connection with the epidermis as well. One of the variants of a hidradenoma that you guys should know about is your clear cell hidradenoma. A clear cell hidradenoma will predominantly have the clear cells and can be confused with your metastatic clear cell renal cell carcinoma. So again, looking at low power of the lesion, recognizing that it has both the solid and the cystic areas. When you go up on high power, it basically is composed predominantly of the clear cells. You can see the niceness of the clear cells within the lesion, but it also has these areas of pink secretions, which will be absent in metastatic renal cell. Metastatic renal cells are very hemorrhagic tumors. We'll again talk about that. This one doesn't have any atypia, and you can again see the nice, dense, pink hyalinized stroma within the lesion. So, that's another clue, and you can see all these secretions, which should not be present in a metastatic renal cell carcinoma. So let me show you an example of metastatic renal cell. These are pretty, metastatic tumors, especially metastatic renal cell, is one tumor that can show secondary epidermal involvement. So typically for Mets, you do not want to see epidermal involvement, but in metastatic renal cell, you may see secondary epidermal involvement, and that's fine. One of the classic clue for the tumor is that it's very bloody and hemorrhagic. So you can see there's lots of extravasated blood and hemorrhage. And in the background of the hemorrhage, you can see these packed nodules of cells with clear cytoplasm. Even though it's a met, typically the cells are not that ugly. But it's not a clear cell hidradenoma because A, you have the hemorrhage. B, you lack the solid cystic areas. C, you are not going to see glandular ductal elements or that nice dense pink hyalinized stroma like what I showed you. So look for all those clues for differentiation between metastatic RCC and your clear cell hidradenoma. The next tumor we're going to talk about is cylindroma and spiradenomas. So cylindromas and spiradenomas, these are again in a similar spectrum. They are very blue basaloid tumors. Cylindromas are classically referred to as pieces of jigsaw puzzle. So you can see these nice basaloid islands which are fitting into each other like pieces of a puzzle. Each of this piece of puzzle is surrounded by this dense pink stroma. This is your type 4 collagen basement membrane. So they can ask you this, what is this pink stroma made up of? And then with the tumor islands itself, again, have two types of cells. You often see glandular ductal elements. You can see the nice sweat gland formation. Two types of cells, the darker blue cells and much more lighter cells. So darker cells and the lighter cells is what you see. The individual nests are going to be like pieces of puzzle. What is cementing them is this pink hyalinized stroma. So that is your cylindroma. This is going to be in contrast to your spiradenoma, which are the big blue balls in the dermis. So when you see the big blue basaloid island, so instead of the nests, instead of pieces of puzzle, you have big blue ball. And that, when you go up on high power, looks pretty much what we saw to a cylindroma. You can see the pink hyalinized stroma, which is again the type 4 collagen. You can see the two types of cells, the lighter and the darker cells, and you can see these primitive glands and ducts being formed within the lesion. Spiradenomas can often be very hemorrhagic. They can have inflammation, edema, so they may often disintegrate, and clinically they often appear as cysts. So you can see this nice stromal edema. There is often hemorrhage, more inflammation within a spiradenoma as compared to a cylindroma. Both these tumors can be associated with Brooks-Spiegler syndrome. So that's a nice example of a spiradenoma. One of the last tumors that we're going to talk about is going to be Your tumors, which are again on a shave biopsy, can be difficult to distinguish between them. So this is a syringoma, desmoplastic trichoep, and a microcystic adnexal carcinoma. So syringoma is sweat gland in derivation, and desmoplastic trichoep is follicular tumor. So we'll talk about both of them. The important thing about a syringoma is that the stroma is an integral component. So you can see this nice, beautiful stroma, which is sharply demarcated from the adjacent dermis. Within the tumor itself, you will see these tadpole-like structures. So you can see these nice ductal elements which have secretions within them, and then these nests and cords. And in places where those ductal elements and the cords are fused, these will form these tadpole-like structures. So that is your syringoma. Again, it is such a classic appearing tumor. If you see it once, you will remember it. That's your syringoma. The more complicated one is your desmoplastic trichoepithelioma. The desmoplastic trichoepithelioma is a follicular tumor. Often, the best way to, no, this is not a desmoplastic, this is again a syringoma. You can see the secretions. The difference between a syringoma and a desmoplastic trichoepithelioma is going to be from the presence of horn cysts versus secretion. So syringoma is going to have the secretions, whereas the desmoplastic trichoep is going to have horn cysts and keratin. So you can see that this is a nice punch biopsy. These tumors often have a central delta. So that's a desmoplastic trichoep. You often have horn cysts within the lesion, and then the infiltrating nests and cords of tumor islands, which will end within the dermis. So they don't infiltrate into the deep dermis, don't infiltrate into the fat. On a shave biopsy, if you're not seeing the base of the tumor, these can be very similar to a microcystic adnexal carcinoma. So that's the next tumor we are going to talk about. So again, you can see the horn cysts, the keratin elements, and the infiltrating nests and cords of islands within a dense stroma. So that's your desmoplastic trichoep. A microcystic adnexal carcinoma is an important board question. These are malignant adnexal tumors, and it's more of their infiltrative growth pattern rather than their cytology that makes them malignant. So these are very poorly circumscribed tumor, lots of infiltration, invasion to the deep dermis and the fat. So you definitely require more surgery to treat them. You can see all these infiltrating nests and cords of tumor islands, which are diffusely infiltrating the entire stroma. An important clue that you're dealing with the MAC is if the lower portion of the lesion has those tadpoles, or even has things which looks like lobular breast cancer with the signet ring cells. So you can see these, which is indicative that this is glandular in derivation in the lower portion. So do you see these kind of infiltrating nests and cords which will have these kind of cytoplasmic lumina? This is similar to what you see the blister cells of like the breast cancer. You can see that in over here. The top portion of the lesion will basically have horn cysts, like a desmoplastic trichoep. So you can see the nice horn cysts, and again the infiltrating nests and cords of island. But honestly, what makes it malignant is the infiltration. So you can see that it's extensively going to the deep dermis and the fat. You often see perineural invasion within the tumor, which is a clue that you're dealing with a malignancy. This is going to be in contrast to your morphiform basal cell, which is going to be cytologically atypical. So microcystic adnexal carcinomas, they don't look ugly, but your sclerosing morphiform basal cells, they will show hyperchromatic basaloid islands, which will have retraction from the stroma, as you can see here, and the individual cells are going to be much more hyperchromatic and ugly, as you can see in over here. So that's a MAC versus a sclerosing basal cell or a morphiform basal cell. The next benign follicular tumor that we're going to talk about, which is pretty classic for this tumor, like if you have seen it once, you will always remember it, is a chondroid syringoma. Chondroid syringoma is also referred to as pleomorphic adenoma or benign mixed tumor of the skin. This is similar to the pleomorphic adenoma or benign mixed tumor which occurs in the salivary gland. So it's an easy tumor to recognize because this is the only tumor that produces the chondromyxoid stroma. So you can see this blue mucinous stroma, and then floating in the blue mucinous stroma are these nests and cords of tumor cells which will have the secretions within them. This is also an apocrine/ecrine tumor, so you can have apocrine cells within the lesion. But nicely, if you see the nice chondromyxoid, the pink stroma, you know that you're dealing with the chondroid syringoma. These tumors often are in the deep dermis and the fat, and they clinically come in as cysts. So that's the location of the tumor. So you can see the nice chondromyxoid stroma. So that is your chondroid syringoma or a pleomorphic adenoma or benign mixed tumor of the skin. The two malignant tumors that I want to talk about, which can be tested, number one is your primary mucinous colloid carcinoma. This tumor classically occurs in the eyelid region. It has a beautiful morphology. It will always look like this. It is multilobular. So you can see these nice, delicate fibrous septae separating the tumor islands. There will be pools of extravasated mucin, tons and tons of mucin. And floating in the pool of mucin are going to be these large cribriforming, cookie cut glandular epithelium, which is going to have these spaces, which is your cribriforming architecture, and with these very monotonous looking cells, like these very cytologically banal looking cells with inconspicuous nucleoli. This morphology is pretty classic for primary mucinous colloid carcinoma of the eyelid, but this tumor is indistinguishable from, let's say, metastatic breast carcinoma to the skin. So before diagnosing this to be a primary tumor, we have to make sure that it's not a metastasis from sites such as the breast, lung, and the appendix, so and the colon. So those four are the most common sites that you want to exclude: the lung, the breast, colon, and the appendix. So this is your primary mucinous colloid carcinoma, with the classic location is the eyelid. The last tumor that I'm going to talk about, which is an important board question, is a porocarcinoma. So porocarcinoma is probably one of the most common of the malignant adnexal tumor, and it's important to recognize it because these can be high-risk aggressive tumors. They can metastasize, they can present with perineural and lymphovascular invasion. So how do you recognize something to be a porocarcinoma? The first time when you will see this tumor, you will always think about a squamous cell. But the difference from a squamous cell is that these tumors, like poroid tumors, because they are poroid tumors, they will have sharp connection with the epidermis and delineation from the epidermis. So you can again see the sharp demarcation, the larger cells and the poroid cells. But now it is malignant. So these cells will be basically more atypical. You will see the infiltration. You can see the nice invasion into the dermis. And the invading areas, they are not squamous because they show glandular elements. You can see these, they are forming these ductal structures, forming these holes and spaces, indicative that this is an adenocarcinoma and not a squamous carcinoma. So you can again see the sharp demarcation and then the invasion in the form of all these glandular ductal elements. So that is your porocarcinoma. So that is an important tumor to recognize. So that was about your adnexal tumors. I think we have covered all of them. Do you guys have any questions? I know we covered a lot. So this recording of this particular presentation will be available. I'll tell Anthony to be available to you. I want you guys to go through it and at least make a list of all the adnexal tumors we talked about. And you should try to remember them in that order. It makes it easy. So you guys let me know in the next class, what do you want to do? I know we have a bunch of things to basically, bunch of like slides to review. So however you want to approach, I can do that. Do remember, I would highly urge you guys to please try to attend the board review, which I think is occurring on, I can tell you the exact dates. I can text that to Maria if you want to forward that. And, because it's going to be a good, thorough revision of whatever we have studied. But we still have plenty, I think we still have classes before that. So however you want me to approach and what you want me to do, just let me know.
Sounds great. Thank you, Dr. Anand. Let's do maybe that first week of May, just the Adnexal study set, if
Okay.
that
So
sounds good
I've
to you.
made, there are plenty of Adnexal study sets. So let's I will send you guys let's at least try to finish two of them. So there is
Okay.
an Adnexal 1, 2, and a 3, and a follicular set. So Adnexal, at least let's try to do the Adnexal and the Adnexal 2.
Okay, great. Let's shoot for that. Everyone has the link, so they should be able to access it. Um,
Okay.
and then yeah, if you want to forward me the board
Okay.
review,
So
I
you
will.
said we have it in the first week of April, our next class, right?
Yes.
Okay, perfect. So I apologize that I had to miss last time. It was just my kids were just like falling sick so much.
No, no worries. It's totally fine. Yeah, I think we're good. So, we'll see you then. And then, yeah, I
Okay.
will forward, I think we got the review link from Anthony, so I'll forward it to everybody.
Okay. And I'll have, as soon as I get off, I'm going to tell him to basically send you this recording and then also share this PowerPoint with you. This has a number of high yield stuff with your syndromic association. So just go through those.
Sounds good. Well, thank you,
Okay.
Dr. Nand.
Well, thank you.
See you soon.
Have a good evening. Bye.